questions from last time. We're going to finish the nervous system today. And there's going to be a bunch of slides that I'm just going to tell you to not pay attention to. All right. Some of this is more anatomy. You can certainly look at it, but I'm not going to test the anatomy. Okay. So if you don't know where some of the physiology that we're talking about is coming from, you could then take a look at these slides to sort of orient yourself as to what I'm talking about. But I won't actually say, pick this part and show me what it is, draw it, or anything like that. So we're going to skip quite a few slides to get to sort of the nitty-gritty. A couple of other things. On e-learning, the answers to the exams, not the exams. You'd love that, wouldn't you? To the quizzes, excuse me, are on there. So you should go back and check why you got things wrong. It's really inefficient. I used to write the answers for everybody. It just takes way too long. So the answer keys to the 2 quizzes you've taken are on e-learning. Look them up. If you don't understand why you got it wrong, if you haven't already looked at it, try to figure that out. You should do that. Okay. Friday exam, hour and 5 minutes. Come in with a game plan. Watch the clock. Okay. Watch the clock. The exam is done. It's printed. So it's all ready to go. All right. So before we start, any questions from last time? Yeah, Marissa.
Can you go over the absolute and relative refractory period?
Yeah. Absolute and relative refractory period. So in terms of an action potential, right? And we're talking about time here in milliseconds. If we're talking about skeletal muscle, neurons, if we're talking about the heart or smooth muscle, it's a lot slower than in terms of seconds. But this doesn't matter much, right? So you have the millivoltage when you have the resting membrane potential, you have threshold. And I'm going to exaggerate this. So I'm going to spread it out. I think this is what your book does, right? So I'm going to take a neuronal action potential. I'm going to make it wider than it normally is, just because it's easier to see. So you have resting membrane potential. Something depolarizes it. Okay. And you get something like that. When in actuality, what it would actually look like is more something like this. Real time if you were looking at it. Okay. All right, so there are 2 time periods, and for every neuron it's different. For every muscle cell it's different. Okay? They're all calibrated slightly differently. So we're going to pick a point here. We're going to draw a line straight down. So this is the action potential, right? So you got to say to yourself, what are all the parts? This is depolarization. Sodium's coming into the cell, right? Voltage-gated sodium channels, probably. Potassium's coming out of the cell, right? You have that graph on, I can't remember what page it is, where it shows an action potential and then shows permeability. So all this crazy stuff is going on, right? Channels are opening, channels are closing. All right. Roughly, there are 2 sections you can break this into, okay? There's an absolute refractory period and a relative refractory period. This becomes very, very important when we get to the heart. Okay? Very, very important when we get to the heart. But it's relevant to all neurons and muscle cells. They all have this. The one in the heart is much bigger. This would be the absolute refractory period, and this would be the relative refractory period. During this period of time here, if you juice the system with more juice than it normally gets, more current, nothing will happen. You could pump as much electricity into the system as you want, and nothing extra is going to happen. If you do that same thing from this point forward, right, in this area here, and you juice the system with extra, you're going to get another action potential. Okay? But here, the earlier you juice it, the more juice you have to use. Okay? The closer you get to this point where it's coming back to the resting membrane potential, the less juice you have to use. So if you hit it right here at this point, the amount of current that you use has to be higher than whatever started this. So let's say that the amount of current that caused this is 4 amps. Doesn't matter what an amp is, right? It's the amount of current. At this point, you may actually have to use 6 amps to get another one to fire. Okay, something like that. At this point, down here, okay, you're probably only going to need 4 amps, and then in between, you'd probably need something in between. Does that make sense? And then if you do this fast enough, you can actually become more efficient to the point where you can actually use less current, and this is that diagram in the book, than you use to activate the first one. Okay? So that's the difference between them. This is designed, this absolute refractory period, the most important thing there, it is designed to protect the neuron from excitotoxicity. It is, in your heart, it is designed to prevent atrial fibrillation, ventricular VFib, right? These are conditions that are very, very real and happen to people where the chambers of the heart, instead of having a clean on-off, they just start shaking. So they don't contract. They sort of contract. They do these little contractions, but those mini contractions, right? Those mini contractions don't move blood effectively. And so you can cause lots and lots of damage. So that's why, again, we have defibrillator devices. And what a defibrillator device, we'll get back to this, does, it actually sends a massive current, a massive voltage through the heart, and that massive voltage actually completely shuts the heart off for a few seconds. And then, because of the way the heart is designed, the idea is that the pacemaker, the SA node, will kick back in, and when it does, now you have a normal heart rhythm again. And sometimes you have to do this multiple times. So this concept really comes into play when we get in the heart, but neurons and muscle cells also have it. You know, if your bicep, if this doesn't work out in your bicep, you're not going to die, right? But if your heart doesn't beat efficiently and move blood, well, then you're not going to get oxygen and nutrients to your cells, and you know your brain can only go a couple of minutes without oxygen before permanent damage is caused. So it becomes a bigger issue with the heart. Whereas if it's your GI tract, you may be constipated. Okay, we have drugs for that. It's not going to kill you. It may make you uncomfortable. If your bicep doesn't contract because of this and it goes out of whack a little bit, then you have a little bit of a convulsion that occurs, a little bit of twitching, which is, again, pretty obnoxious, but it's not the end of the world. But in the heart, it becomes a super big deal. Does that answer your question? A little bit more than maybe you wanted, but I like to give you the examples to sort of put it into perspective what that really means. Other questions? Okay, so we're going to continue on here with, if somebody might lower, please, thank you. Histamines. Did we talk about the histamines? We did. Okay. Okay, so more of these amino acid transmitters. That are excitatory, aspartate and glutamate are amino acids, right? They're a form of amino acids, glutamine and the other amino acids. These both will bind to a glutamate receptor, and glutamate is the most abundant excitatory neurotransmitter in the body. So most of the excitatory activity that occurs in your nervous system occurs because of glutamate. Not all, but most. When it comes to inhibitory, GABA has that same role on the other end, and then glycine is also involved. Okay, so these are the most abundant excitatory and inhibitory amino acids. So if you took away all the other amino acids and neurotransmitters, you would still be able to function because these do most of the work. Okay. So glutamate is estimated to be primary neurotransmitter at 50% of the excitatory synapse. That's pretty good. All right. There are two types of receptors for these glutamate receptors. They're what are called metabotropic, and the metabotropic glutamate receptors are used the G protein couple receptor. All right. And these are the ones that can affect your metabolism and are affected by a chemical, a ligand, or affect the movement of a ligand. Ionotropic glutamate receptors, and the examples here are AMPA and NMDA, are actually attached to an ion channel, very much like the neuromuscular junction. That acetylcholine receptor is actually an ionotrope, meaning that it allows a sodium channel open. That's what these do too. So they're physically attached to an ion channel. So when they get activated, they let some ion in. Usually it's positively charged. Sodium, calcium, magnesium. It's usually sodium. Okay? And then these are two subcategories. So in the field of neuroscience, AMPA and NMDA receptors are talked about a whole lot. Because they're everywhere. They're really important. You don't have to know the name, the full name. Alright? Just know NMDA. When it comes to glutamate receptors, there are two types, metabotropic and ionotropic, and then there are two examples of ionotropic, and they're called the AMPA and the NMDA receptors. They're not exactly the same in the way they work. They bind things a little bit differently. Downstream, they do some different things. But in the big picture, they're similar enough. Okay. Long-term potentiation. All right. So this is a little bit hard to explain. So I'll read this first. This mechanism couples frequent activity across the synapse with lasting changes in strength of signaling across that synapse, and is thus thought to be a cellular process underlying learning and memory. We actually have in my field the neurocontrol of reading. There's a researcher by the name of Gordon Mitchell. He's down in Florida. He was at the University of Wisconsin for 20 plus years. He actually studies long-term potentiation in people that have been partially paralyzed. So what he does is he exposes people to hypoxic gas. The gas that he makes them breathe is like going to altitude. He removes the oxygen. So in the atmosphere that you're breathing right now, there's 21% oxygen. I don't remember what he uses, but let's say he uses 14% oxygen, 10% oxygen, which is a pretty good load. If you're only breathing 10% oxygen, you're huffing and puffing. Okay? So what he does is he exposes them to this hypoxia over several minutes, starting and stopping. Okay? And what he has found is that this causes a long-term potentiation, meaning that it somehow creates a signal to the central nervous system so that people can begin to walk again. It's really, really interesting. He juices the system, essentially, what it is. There's something about being exposed to hypoxia that does this. And so that's my example of long-term potentiation. He exposes them to lack of oxygen, and somehow this gets converted in the central nervous system to do some healing in the central nervous system, the spinal cord. And it causes them to be able to then move. If you only do it once, it goes away. But if you continue to do this to them, they continually get better. It's really, really interesting. The same thing happens with memory frequency. If you juice the system once, you do it a little bit here, a little bit there, a little bit there, you sort of remember. So if you think about it in terms of studying, if this is true, it is, then you're actually better off touching a topic when you study more frequently as opposed to hitting it one big chunk. And he sees the same thing with these partially paralyzed patients. If he hits them with a hypoxia for an hour, he doesn't see much. But if he hits them with this hypoxia for a couple of minutes, stops, a couple of minutes, stops, and he does this over and over again, day after day after day, they actually start to get better. Yeah, they.
What's the difference between this and like autism? They sound pretty similar.
Yeah, so plasticity. His question is, what's the difference between plasticity and long-term potentiation? Long-term potentiation amplifies something, and it continues to amplify. Plasticity is when one part of the nervous system takes over for a damaged part of the nervous system. So plasticity is a replacement. Long-term potentiation is saying, I'm going to make something better over time and make it stronger. Yeah?
Would living at altitude stimulate long-term potentiation?
No. Would living at altitude stimulate long-term potentiation? Not in this case. Because when you're at altitude, right, you're there for an amount of time. So the only way to do this, and the way he does it in his lab, is they expose people via machines that can pump the gas in and stop it using solenoids, right? They pump it in for a couple of minutes, they breathe it, the breathing rate goes up, they measure it, they start to come down, they do it again, they do it again. At altitude, you're constantly being exposed.
So it's not the hypoxia, it's the up and down.
It's a combination of the up and down with the lack of the oxygen. It's interesting, and this is somewhat related, but not completely. One of the mechanisms that causes muscle hypertrophy, the muscle getting bigger, is actually hypoxia, is lack of oxygen. And they've actually done this. If you've ever read anything about restrictive studies where they take a muscle and let's say you can curl 100 pounds, right? You take 15 pounds, you put it on the bar, and you constrict the muscle pretty tightly. And you have that person go through those repetitions, right? So there's constriction. And what it does is it constricts the blood vessels, so the flow in is restricted, and those blood vessels get exposed to lower levels of oxygen. And they've shown that you can actually have the same level of muscle hypertrophy with that 15 pounds as you would have with the 100 pounds. So there's something about being exposed to low levels of oxygen at a level that's not terminal, right? Over time, that we've evolved to respond to in a good way. And we see it with the long-term potentiation with these partially paralyzed patients. We see it in another field with muscle hypertrophy. We see it in lots of places. You know, the understanding of why and how that works, we're not so sure of yet, but for some reason it works. Memory is not quite like this, right? You're not, when you learn, you're not becoming hypoxic in your brain. You may think you are, but that's not the same. But the point is the same, right? The point is you're exposing yourself over time, brief bouts, and those brief bouts then amplify, in this case, the example they use, learning, which is true, because if you've ever seen something that's called the curve of forgetting, it actually does work. So there's some cellular molecular biology involved in that. It's kind of really cool. So long-term potentiation, the long and the short of it is you do something in brief bouts multiple times, and whatever it is that you're doing amplifies what's downstream. So it gets stronger. In this case, the memory gets stronger, the movement gets stronger, the muscle gets bigger. That's the gist of long-term potentiation. Okay. So this is just a diagram of glutamate and how it works. So you have long-lasting increases in glutamate synthesis. So how can you, on the presynaptic and the postsynaptic side, what happens? You can see that when glutamate binds to a glutamate receptor, it allows sodium to come in. Okay? It allows sodium to come in. It can also, okay, and this is an AMPA receptor. The NMDA receptor actually allows calcium to come in. So they work a little differently, right? They're both glutamate receptors. They're both ionotropes. But this one allows sodium to come in, and this one allows calcium to come in. So they're a little different. But they're both positive ions that come into the cell and polarize and cause an action. So I guess that's the important part of that diagram. You know, you don't have to know all of this. Don't memorize this. I'm not going to ask you this, right? This is just showing you the steps of what would occur. I mean, if you want to read it through to sort of understand it, but I'm not going to ask you, give me the 8 steps and glutamate actions. That's just 4 ingredients. Okay. Let's see what we want to talk about here. This is just what I just showed you in that diagram to explain it. Okay, GABA. Gamma aminobutyric acid. I don't care if you memorize that GABA is gamma aminobutyric acid. You need to know that it's a major inhibitory neurotransmitter. It's not one of the 20 amino acids used to build proteins, right? But it's considered an amino acid neurotransmitter. And GABA, remember, this is having an inhibitory signal so that it dampens. It nullifies part of an excitatory signal. So again, it's a tweak, right? This inhibitory signal. It's toning something down. And the way this one works is it creeps in, it opens up a chloride channel. Which direction is chloride going to go? If the chloride channel opens up in a cell, which way is chloride going to move? In or out of the cell? In. That's right, because that's the direction of the electrochemical gradient. What's it going to do to the cell when it moves in? Let's assume that the cell is already at resting membrane potential. Use this diagram. What's it going to do to the cell? It's going to hyperpolarize it. It's going to make it more difficult. So this after hyperpolarization here, if you opened up a GABA channel, right, all of a sudden you'd see this. Now it's going to take that much more to get up to resting membrane versus just that, right? So you can see it's going to take longer and it's going to take more effort and energy to depolarize the cell. That's what these channels do. All right, benzodiazepine, Valium. Okay, Valium is taken by people who are very anxious. Okay. Xanax, same thing, just a newer version of Valium. In my day, in the 80s, everybody talked about Valium, now everybody talks about Xanax, same stuff. All right. Some people take it to reduce anxiety, so if you're the type of person who's very, very anxious, extremely anxious, pathologically anxious, like all the time, sometimes these people take Valium or Xanax because you can't be anxious all the time. That's just not normal. If you're anxious all the time, that's problematic. Guard against seizures. Some types of seizures can be quelled by Xanax. Some people are so anxious that they take Valium just to go to sleep. Now, Valium's not going to kill you. You can't overdose on Valium. It just makes you sort of tired. You don't really want to do stuff. Because this also increases the chloride channel influx. So it activates a GABA receptor is what it does. Again, it's not going to kill you if you overdose on it, but it kind of makes you, it's sort of like doing weed, right? You're sort of semi-non-functional, really, is what you are. But you're not going to have that sort of euphoria either, like, right? And it's not going to be talking like that. You're just not going to be very functional. So, typically people take this at times when they're not operating heavy machinery, probably not supposed to be driving, I don't know, trying to play sports, things like that, right before bed, or in the evening when you're not moving around. Okay, so those are benzodiazepines. Barbiturates do the same thing. Now, the difference is barbiturates will kill you. They will kill you for sure. All right. So barbiturates, not only do the Valium products, the Xanax and the Valium, diazepam, they decrease anxiety, but the barbiturates also severely depress breathing. And that's why doing barbiturates will kill you if you overdose on it. Valium does not do that. Okay. So that's why it's hard to kill yourself with Valium. Not a good choice. What else I want to talk about here? Ethanol. Okay, alcohol. Right? stimulates GABA synapses. That's one of the reasons it's a depressant. Now, the thing with alcohol that's problematic is, depending on the dosage, high doses of it can activate lots of GABA synapses. Everybody knows that there's several types of drunks, right? That's right. And so some people actually get jacked up when they drink. So it can actually be a stimulant to some people. And then some people, then there are those sleepy drunks, right? They just have a few and then they go in the corner and they go. But other people have the opposite effect. So depending on the dose, and this happens with a lot of different drugs actually, depending on whether you're giving a very low dose, a medium dose, or a high dose, the effects could be 180 degrees separate from one another. So ethanol, while it does stimulate GABA synapses and is a depressant overall, we know this in very high amounts, small amounts can actually create the opposite effect. For some people, right, it's liquid courage. For some people, yeah. So that's an important thing. Yeah, this goes without saying. Very high doses of ethanol sometimes fatal due to the suppression of the brainstem centers for regulating cardiovascular and respiratory control. So drinking too much, what it actually does is it depresses your breathing and heart rate to the point where you can't sustain life. That's how it can kill you. Glycine. What do we want to talk about glycine? This one also binds an ionotrope. Does the same thing as GABA. And then ionotrope will allow chloride to come in. So it's very similar. It's a different ligand that binds, and what's downstream from that ligand is very different too. But the overall effect is essentially the same. The interesting here is that in poisons that use this glycine receptor, strychnine is an antagonist to it. So strychnine is actually an antidote to any poison that uses this glycinergic system. And if you apply strychnine, it's a competitive inhibitor, so it blocks the receptor binding site so that glycine can't bind. That's what strychnine does. All right. You can read this. Okay. Endorphins. Let's talk a little bit about endorphins. Endorphins, getting back when we were talking about oxytocin the other day, there are 3 types of endorphins. They're part of this runner's high. You can get this type of runner's high from lifting weights, you can get it from running, you can get it from doing any type of activity that's pleasurable. It's a little different than dopamine, but it has a very similar effect in that when you have lots of endorphins in your system, when you have lots of dopamine in your system, you just feel great, right? But when you have lots of endorphins in your system, you feel great and you don't feel pain. So if you've ever had this experience where you're playing some kind of sport or doing some kind of activity, rough and tumble, depending on what the sport is, and you're smacking around with different players on opposite teams, depending, again, on what your sport is, and you're fine, right? Because you've got these endorphins with more blood flow that are flowing through your system. And then a couple of hours later, when everything sort of calms down and the endorphins go away, all of a sudden you realize that your body hurts everywhere, right? And the endorphins at that time, plus the epinephrine and the norepinephrine, prevent you from feeling that pain. So it's probably evolutionary in that, not that we evolved playing sports, but when we're doing activities where there was a lot of conflict, usually it's trying to kill something to eat it, and sometimes that thing that you're trying to kill and eat is as big or bigger than you are, sometimes, right? And things would happen. And if we didn't have these endorphins, right, you'd feel that pain right away to a level which you couldn't sustain whatever the activity was. And so these endorphins help you get through that. But then afterwards, you pay the price. And if anybody that's ever played a sport or done an activity like this, that's exactly what happens because the endorphins go away. Okay. And these are all opioids. Morphine, codeine, right? Oxycodone are all Vicodin, are all opioids. And very, very addictive. Heroin, opium, extremely extremely addictive, right? They work great, but they will make you loopy. If you've ever been on one of these, they work great. And you get to the point where you're like some NFL players who you have to take 2 or 3 Vicodin just to be able to get up in the morning and to get to practice. That's never a good sign, right? So there are people that live on morphine, codeine, Vicodin, oxycodone, and they help reduce pain, but they're also super addictive. So part of the heroin problem that's, at least it's missed in Wisconsin, New Hampshire has a really bad one too, East Coast, is because people coming back from the Iraq and Afghanistan war were on these things and they were overprescribing them. And then what ended up happening, the VA finally said, we're cutting you off cold turkey. Well, if you're a drug addict and don't know it, you're going to go looking for other forms of it. And that's what's created this heroin problem in the United States. Very, very addictive. Right? So if you don't need them, just take aspirin, take Tylenol, take ibuprofen. Right? Substance P is another excitatory neurotransmitter, so you just need to know that it's substance P after pain. So when you do something that causes pain, substance P will transmit that signal from the point of the pain back to the central nervous system. But it's excitatory, right? It's going to send your system, whoa, something not really good is happening. And then we talked about nitric oxide. We're going to talk about nitric oxide again, and there are different forms of this when we get to blood vessels in the cardiovascular system. Okay? We'll talk a little bit about chocolate. Chocolate's involved with nitric oxide production. So you should know that it's just a neurotransmitter, and it's involved with blood vessels. And then we talked about the purine, and I gave you the example the other day of coffee, caffeine. Right? So all of this we've already gone over. All right. So we're going to do a little bit about this diagram. Not that I want you to know the diagram, but it's schematic to use. If you take a look at the central nervous system, and then you take a look at the peripheral, right? We talked about afferent, stuff that goes back to the central nervous system, and we talked about efferent. Okay? So you've got somatic sensory. This is a sensation in areas that you can control. The somatic nervous system helps you do voluntary movement. Okay? There's visceral. This is all the stuff that's in your gut here, underneath your lungs, stomach, liver, pancreas. And then there's special senses, eyes, ears, and 5 senses, right? So this is all the stuff going back. The stuff coming out has 2 divisions. The somatic, so that I can move around here, right? Move around, I'm shaking my arms, doing my thing. And then you have the autonomic, all right? Which you can think about as the automatic nervous system. It's not, but it sort of works that way, right? And there are 3 parts to this. This is the sympathetic, the parasympathetic, and enteric. Enteric has to do with your GI system. We don't touch it in this class, unfortunately. I just don't have time to do GI physiology. But what we do touch a lot is parasympathetic and sympathetic. So you should know that the parts of the peripheral nervous system, that the efferent division, you should know these 2, right? And these different parts. But from the autonomic, we're going to focus on sympathetic and parasympathetic. We're going to do it for skeletal muscle, we're going to do it for the heart, we're going to do it for the blood vessels, we're going to do it for the respiratory system, we're even going to do it for endocrine, and we're also going to do it for renal. So it's everywhere. You can't avoid it. Enteric is specific to the GI system. We're not going to worry about it. Okay. So now we're going to skip. So if you've never taken an anatomy class, if you haven't taken one in a long time, and you want to know where these parts are, certainly take a look at this, but I'm not going to ask you any of this. Identify, right? So a lot of this is what the forebrain does. All of this stuff you can just skip. Okay? I did this last semester in anatomy, so if you took anatomy, you've already done it. If you haven't, you didn't miss much. It's cool, but I'm not going to talk about it. I just don't have time. But certainly, again, if you don't know what these things are, we did cranial nerves last semester. We're not going to do it this semester. We got them. You want to know what a cranial nerve is? That's fine. Right? Spinal cord. I will talk a little bit about this diagram. Okay, we also did this last semester. Okay, But, so the important thing is, so this is your vertebrae, right? This is the anterior side, so the front side of your body. This is the posterior, the dorsal side, okay? Your spinal cord sits right behind this big old bone, and there's a bunch of them, right? Your vertebrae. And these things are really, really strong and protected, right? And then you have these other parts. Okay, so you have your spinal cord here. You have the ventral side, or the anterior side. That's where stuff usually goes out from, that's the efferent signals usually come out of the ventral root. And the dorsal side is where stuff comes in, on the back side. So that you should know, because the efferent signals go in this way, and the afferent signals come in this way, and the efferent signals go out this way. So that's one thing you should know. Am I going to ask you to draw the diagram? No. But you should have a sense of where this is actually happening. The other thing is that most of the nuclei, okay, a nucleus in the central nervous system is a group of cell bodies. So what do I mean? So if we're looking at the cell bodies, these are neurons, right? These are the cell bodies, or the soma. Most of those occur within the central nervous system, and then the axons, the projections, can go very far away. When a group of these that do similar activities come together in the central nervous system, it's called the nucleus, which is spelled exactly like the nucleus in a cell, which would be in here. They're not the same thing, no. Okay? But in the peripheral nervous system, anything that's outside of the brain and the spinal cord, you also have groups of neurons like this that exist. And in those, they're called a ganglion. Now, why am I saying this? Because there's a picture of one here. All right, so in this area here, in the gray matter, are nuclei, because this is part of the spinal cord, which is part of the central nervous system. This bump here, okay, this bump here is a ganglion. That means that there are similar types of cell bodies in here that there are here. And then in between there are just axons and dendrites. There are no soma outside of these two types of areas. When you go into medicine, it becomes super important because they'll talk about the cervical ganglia, right? The sympathetic trunk ganglia. And what they're talking about is these bumps that come out of the spinal cord here and eventually form, these are the spinal nerves, right? So these are the nerves that actually come out of the vertebrae. These are the ones that get pinched when you have herniated discs. If you have pain, that's this. And so that means that information that's coming into the spinal cord and leaving has problems. So maybe you're not getting, if you have herniation or compression in your neck, and it's affecting the spinal nerves that affect your right arm, you may find out that you can't grip things anymore, right? If something is weird, that's because this area is being compressed. Okay, so you have these ganglia, and a ganglia is just a group of neuronal cell bodies that are in the peripheral nervous system. So you have to know that. Do you have to be able to draw this and label this? No. But I want you to see what it is, because it's very, very important to sort of have in your head, yeah, there's a tube here, there's a bunch of connections, there's an in and an out, and then there's a bump. Good enough. Questions on that? I'm telling you this because I'm going to then show you how the synapses are set up. And if you don't have this in your mind as a picture, then when I'm going to show you what the synapses, when we get there, it's not going to make any sense at all. You don't need to know this. Again, there's a lot of stuff here. Don't worry about this either. None of this. Cross it off. Okay. Again, these are the spinal nerves. If you get to medical school or PA school, you become a physical therapist, an occupational therapist. You need to know the spinal nerves, right? Because they're coming out. Because you're going to be treating patients that have these problems. So you'll have to memorize them. Here's the sciatic nerve, right? People that have problems with their hip and they lose feeling in their leg. Here's the big old sciatic nerve coming out the bottom here. It's another type of spinal nerve. but you don't have to know them in my class. But you should just know that they exist. And then this shows these ganglia here. Okay. This is important. Now here's where we start. This stuff is important. Okay. So the peripheral nervous system, somatic and autonomic division. So you've seen the picture, right? The breakdown. So if you can't remember that, hold on. Sorry. This is a good diagram to memorize. I'm not going to ask you to write it, but I think it's good to know so that you in your head, when we talk about this stuff, say, oh yeah, these three parts go to this, and then these parts go to this, and these three are part of this. You have to know that. You have to draw it. Am I going to ask you? Probably not, but I'm just going to assume you know. Okay. So in that somatic, remember, somatic nervous system has to do with things you can control. Pretty much your skeletal muscle system. All right, things you can control. So consists of a single. Now I'm going to read this quickly, but then I'm going to show you the pictures that go with this. I like the pictures better than the words. So if you're a picture kind of person, this isn't going to help you. But if you're a word person, this might help you. All right, the somatic system consists of a single neuron between the central nervous system and skeletal muscle. I've already shown you an example of this with what kind of synapse? What do we call this synapse? I've used it probably 5 or 6 times since the beginning of the semester. The neuromuscular junction works. So somewhere in the spinal cord or in your brainstem, you have these motor neurons, and they have really long axons, and then they connect to the muscle. That's it. Motor neuron, axon, way outside of the central nervous system, neuromuscular junction. So all of these types of junctions look that way. They're really, really long. Okay? Innervated skeletal muscles can lead to muscle excitation. In the autonomic nervous system, it's a little different. They don't look this way. The system is set up differently. It has a 2-neuron chain connected by a synapse between the central nervous system and the effector organ. And we'll see what this means in a second. It innervates smooth muscle, the muscle around your stomach, the muscle around your intestines, the muscle around your blood vessels, smooth muscle, cardiac muscle, your heart, glands, your sweat glands, all right, cerumen glands, GI neurons, that's the enteric nervous system that we're not going to talk about, but not skeletal muscle cells. The autonomic nervous system does not innervate skeletal muscle cells. There is no wire from this part of the system to the skeletal muscle. That's really important to know. Okay? And then it can be this system can be either excitatory or inhibitory. So that's important to know. Questions on that? So a lot of this is enteric. You don't need to know anything about the enteric nervous system here. You can read through this. I really want to focus on, you can read through this, fight or flight. We're going to talk about this, rest and digest in a second. Again, read through this. What I want to get to, and this is complicated. You're not going to memorize this either. But what I think is important from this slide is the following. Is it's really complicated, right? You don't have to know this, but what you have to show, and I'm not going to ask you this, but here's the central nervous system, right? Here's the spinal cord, and these are the different ganglia that exist. So if you get to medical school or PA school or any of these schools, you're going to have to memorize this: the superior cervical ganglia, right? The middle cervical ganglia, the inferior cervical ganglia. You have the superior mesenteric. So there are all of these ganglia. And you got to know what the hell a ganglion is. Well, all it is a bunch of neuronal cell bodies that sit in these bumps that are outside of the spinal cord. That's all it really is. It's a fancy name for that. It's an extension. And then it shows you all the connections. So, again, we're not going to do all of this, but I'm going to show you a much more simple diagram. This. All of that stuff that I just skipped, that I said read, essentially refers to this. This is the simplified version of 5 or 6 slides that I just skipped. So if I were you, you're like me and I love pictures, right? I would much rather start with this thing, try to figure this thing out, and then go back and fill in the blanks with the words. You start reading those words, they're going to mean nothing to most of you. You're wasting time. Start with something concrete. This is concrete. I think everybody in this class, everybody in the other class should be able to wrap their mind around what I'm going to teach you here. Okay, in the very first one here, here's a motor neuron somewhere in the brainstem of the spinal cord with a super long axon. It releases acetylcholine, and the muscles have a nicotinic acetylcholine receptor. So they're all like this. So you have one piece in the central nervous system, you have this in the peripheral nervous system, and then you have its connection. That's the way it is, super long. These are the longest cells in your body, this, right? Because they can go from the high parts of your neck down to your feet and beyond, right? So this is the new stuff, the autonomic nervous system. Okay, in the very first kind of connection, you have some kind of a neuron in the central nervous system. It's a relatively long axon, and it goes to a ganglion. Now you know what a ganglion is, right? The ganglion's here. It goes to one of these things. That's what that middle piece is. It's a transition zone. Okay. And this is for the parasympathetic part. This is the rest and digest part of the autonomic nervous system. When you do yoga, when you meditate, when you listen to a really relaxing piece of music, when you're just, relaxed. This is the system that's activated. In the ganglion, this also releases acetylcholine. In the ganglion, this is also a nicotinic receptor. Same receptor that's here. So this is excitatory. Okay? This is excitatory. Here's where it gets a little confusing. However, then you have a postsynaptic neuron or a postganglionic neuron. So if you read these terms, this is not only is this part of this is part of the central nervous system where this starts. This is part of the peripheral nervous system. In this ganglion, this is not only a postsynaptic neuron, but is also a postganglionic neuron. Okay? Postsynaptic is very broad. It just means it's the neuron that's on the opposite side of the synapse. It could be any neuron, pair. Postganglionic means that the neuron that comes before it and the neuron itself are what's in between them is a ganglion. Okay? What's in between them is a ganglion. That's the connection to it. So this is the pre-ganglionic neuron. And this is the postganglionic. That's much more specific than saying presynaptic and postsynaptic, because this can happen. This is presynaptic and postsynaptic, but this is not preganglionic or postganglionic. Why? Why can't I say that this is preganglionic and postganglionic? What's the difference between this and this? Aren't they both synapses? Is this presynaptic? Yes. Is this presynaptic? Yes. Postsynaptic? Yes. Postsynaptic? Yes. Preganglionic? No. Why? Because there's no ganglion here. That's the difference. There's no ganglion involved. It's that simple. So the terms are not interchangeable. So you have to have a command for the terms. If you don't, you're going to confuse this. You're going to be using them interchangeably, and you can't. You can't. Okay? So this is excitatory. This postganglionic neuron then also releases acetylcholine. Okay? So at the neuromuscular junction, you get to a nicotinic receptor. Acetylcholine is excitatory. From the preganglionic to postganglionic neuron, acetylcholine is excitatory. With me? But in the parasympathetic nervous system, this synapse here between this postganglionic neuron and whatever it affects, smooth muscle, heart, and glands, actually binds a muscarinic receptor. This is actually inhibitory. and the effect is inhibition. Right? So when you activate this part of the autonomic nervous system, yoga, meditation, relaxing music, what happens to everything in your body that's associated with smooth muscle, cardiac muscle, glands? Right? These things, they tone themselves down. They may even hyperpolarize, and you become relaxed. So it's called rest and digest. Right? So excitatory, inhibitory, and this is the one that counts because this is the effector right here. What's in between is just a mechanism for getting this message to here. This is inhibitory. Okay? So in the blood vessels, when this occurs in blood vessels dilate. When you relax, what happens to your blood vessels? They dilate, they get bigger, a little bit. The sympathetic nervous system is part of your fight or flight nervous system. So it is your emergency response system. Okay? So you activate it in times of need. If you play a sport, you activate it all the time, right? Your body doesn't know the difference between a sport versus something that's trying to kill you. The system activates the same way, just at different levels. All right. So in the sympathetic nervous system, the preganglionic neuron is super short. This axon here is teeny tiny. So that means that this ganglion that it attaches to is very, very close to the spinal cord. Kind of like what I showed you. Very, very close. So again, this is a preganglionic neuron. This is postganglion. Here, again, you're still using acetylcholine and nicotinic acetylcholine receptor. So this is an excitatory synapse now. Excitatory synapse, excitatory synapse, excitatory synapse. Inhibitory synapse. Okay. This causes excitation of skeletal muscle. This causes things like blood vessels to dilate. Here, the postsynaptic neuron releases norepinephrine. What type of a neurotransmitter is norepinephrine? Oh, you have a 50-50 chance of getting it right. It's either excitatory or inhibitory. It's excitatory. This is part of your fight or flight response. So the ultimate response here is, in smooth muscle, it's going to contract, right? Your blood pressure is going to go up. Your eyes are going to dilate, right? All of the things that you think would have to happen so that you're ready for a fight, essentially. That's what it is. It's part of the fighting part of your system, right? So, and then, finally, in this last part of the sympathetic nervous system here, right, you have a neuron that is preganglionic, right? And in this case, it's not even a ganglion that's in the middle. It's the adrenal gland. So the adrenal gland is the middleman here. Again, it's very much like this in that it's short, and it's also like this in that acetylcholine is released, but then the adrenal gland then releases epinephrine. So when we talk about the two major communication systems in your body, and when we talk about fight or flight, this is the nervous response to a fight. This is the endocrine response to a fight. Here, you release norepinephrine and it excites whatever's downstream. Here, you release epinephrine and that continues the excitation that this starts because these two systems usually fuse together somewhere. So where you have these, you have these. Does that make sense? This is a shorter response and faster. This is a response that's sustained. So if you're nervous all the time, if you're anxious all the time, you're jacked up. This part of the system is overly excited all the time. You're going to burn it out. Think about this scenario. You're anxious all the time, right? You're always anxious. So you're pumping out norepinephrine and epinephrine here. What's associated here is also cortisol, which is another stress hormone, which is going through the roof. And then you're not sleeping, which elevates cortisol even more, which is not good. Then you're jacked up on 5 or 6 cups of coffee because you can't stay awake, which jacks the system up even more. And now you're blocking the adenosine receptor, which jacks the system up even more. And so there's a condition called adrenal fatigue. It's real. Where you basically, this thing is so active for so long that it starts to burn out. And it won't, not only will it not produce as much epinephrine, but you become insensitive to epinephrine. Just like insulin insensitivity. When you keep pumping out too much insulin because you're eating too much sugar all the time, you become insensitive. Your body won't respond to it anymore. So today I have to drink 1 cup of coffee. Tomorrow I got to drink 2. The next day I got to drink 3. I, in graduate school, tell this story all the time. When I was getting my PhD, I measured the amount of coffee that I drank in terms of pots, not cups. I'd get home and I'd put my first pot of coffee on. And I probably already had a pot at work. My first pot. How do you think I felt? Terrible. All the time. You get to the point where you're on the 3rd pot for the day and you're still tired. You know the best advice I ever got from somebody was? It's from an MD PhD. She's an anesthesiologist in Iowa. Go to sleep. So I did for 2 days. And that cured me. That was the fix. That was as simple as that. I felt much better. So that's how you can abuse this system to the core. And I did it better than anybody at the time. I was just doing a great job killing myself. So you don't want to do that. This is a system that was designed for short-term use, right? Because you're not supposed to be fighting 24 hours a day, right? You're not supposed to be fighting anything 24 hours a day, including yourself. So the system's not designed to handle that load. It doesn't know what to do with it. So it just starts shutting itself down, right? So, super important. You got to understand this. We keep coming back to this over and over and over and over again. This is as important as the intracellular and extracellular concentrations. It's as important as understanding osmolarity because we keep coming back to it. So I would have this diagram pasted in your binder. Certain things, very, very important. Keep referring back to it. Right? You need to understand the differences on the lengths of the axons here, what's released, and what's excitatory, inhibitory, excitatory, 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 excitatory. This diagram basically explains 1, 2, 3, 4, 5, 6, 7 slides. In a nutshell, what I just gave you is 7 slides worth of lecture. You're more than welcome to look through it. I think you should, but you should understand the diagram first. Okay. Lots of stuff there. Questions on this? Does everybody see how you can have excitatory synapses in between inhibitory, and it really is what's at the end of the road that's the most important, not how you get there. Right? You can't say, well, this is excitatory. You're going to get excitation here. No, you're not. No, you're not. That's not the way the system is designed. Questions? Cerebral spine, you don't have to worry about this. Again, this is more anatomy. No. All right, so we'll just talk a little bit about cerebral spinal fluid. In just that, you need to know that essentially the components of the cerebral spinal fluid, and it's flowing through your brain and your spinal cord. We talked about where it's made in the ependymal cells in the ventricles, which are these holes in your brain. And that it basically, if you can think of it like the plasma from your blood, so there's no blood cells in there, just the plasma portion, sort of the same idea. Does very much the same types of things that the blood does without the red blood cells. Not exactly, but close enough. You make about 400 to 500 mils of this a day. You don't really have to know that, but you need to know what cerebral spinal fluid is. Hydrocephalus, we talked about, is water on the brain. Last semester, if you were with me, we saw a picture of a baby. Looks like a big alien head. They drain the system, and the baby's head goes back to normal. That's what hydrocephalus is. Blood-brain barrier. This is important. we talk about this all the time, and a lot of people don't know what the hell this is, right? The blood-brain barrier, it protects something, it's a barrier. Okay, well, thanks, Sherlock, right? It protects something, it's a barrier. All right, so it is a protective mechanism that helps maintain a stable environment of the brain. So this I'll read. Substances in the brain's capillaries are separated from the extracellular space by a continuous endothelial cell line. So astrocytes within the central nervous system, they innervate, means they come into the blood cells, these capillaries, and the endothelial cells are the cells that are inside of the capillary. So a capillary, most of the capillaries in your body are one cell layer thick, and that cell layer are these endothelial cells. And what it does is it causes tight junctions to occur. These tight junctions don't occur in many places in your body, and certainly not in blood vessels, which means that the walls of the capillary are fused. Capillary walls are not normally fused, they're actually very porous. Most of the capillaries in your body, water moves in and out of them like the walls aren't even there. These are specially tight. Okay? Why is that? So they form these tight junctions, thick basal lamina. You can take anatomy, we don't worry about what basal lamina is. The feet of the astrocytes surrounding the capillaries contribute. So what does that mean? This blood-brain barrier was designed so that only certain types of substances can get from your circulatory system into your brain. Not everything can pass it, including some antibiotics. In my PhD, we worked with goats. We did brain surgery on them. We would implant big pieces of acrylic and stainless steel microtubules into their brain, doing brain surgery. And we had to be able to find a drug that could penetrate this blood-brain barrier, because if there was an infection in the brain, most antibiotics will not cross this barrier. So you give them to the goat, and the goat still is sick. So there are very few antibiotics that are around that are small enough, that have the physical and chemical qualities that allow them to go into the brain. And so when you do brain surgery, when you have something going on in here, other than injecting it straight in, which is always an option, right? If you have a hole in there, you can inject it in. If you're going to inject it into a vein, you got to make sure that whatever that substance is can actually pass this. If not, you might as well be injecting tap water. It's not going to do anything. So that's what this barrier does. Now, gases can penetrate this. CO2, oxygen, nitric oxide. Those types of things can do. And when we get to the respiratory system and the renal system, when we're talking about gas regulation and hydrogen ion, because hydrogen ion cannot penetrate the system. And yet your brain can become acidic. So the question is, how the hell does that happen? If the hydrogen ion can't go from the blood into the brain, how does the brain become acidic? There's a way to do it, and it involves a gas. Okay. So that's what this thing is. If you actually drew it out, it would look something like this. So you have these capillaries that have these cells. Normally a capillary looks like this. And there are these huge holes in it. But the astrocytes, right? The astrocytes, these glial cells, form these tight junctions. And now you can't move stuff in and out of there so easily anymore. It's very selective. Don't worry about this. This is basically a stroke. Head injuries, that's it. We're done. All right, so Friday exam, I will try to get here early. If there's nobody in here and you come early enough, you can start. You have until the end of the period, and I think there's another class coming in here. If there isn't, there is one after my second class, and so I have to give the same amount of time. Watch the clock, study hard. Okay, if you have any questions, let me know. Good luck. Remember, the quizzes, answers, online. Check it out. Yes, sir.
Curious wise.
Oh, I can do it. Yeah, I'll probably do it today.
We'll watch. I mean, if not,
Yeah, no, I can do it. It doesn't take I have another one at grade 2, so that should be pretty easy. Stop by.
So you inject that in, and then by osmosis you would think that. So if you have the capillary here, they can just get water get through here.
Okay.
Blah, 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 blah. You
Yeah.
have a hypertonic solution.
What kind of a hypertonic solution is it? Penetrating or non-penetrating?
It would be non-penetrating.
Okay.
So
So it's a
Are you talking about the
non.
practice problem or no?
yeah, I'm thinking about the practice